Hello everyone, welcome to my video channel. Today I am going to continue regarding damage control orthopedic DCO part 2. In today's video, I am going to cover regarding Atls, Advanced Trauma Life Support, with interventions regarding classes of hemorrhagic shock, what is the response to fluid challenge and resuscitation, what is the rapid responders, transient responders, and the non-responders. How do you do resuscitation? How much blood loss in patient who has certain fracture? As my previous video, the disclaimer is the same. Okay, now I want to give you a scenario. Let's say you are asked in Viva, example, a 20-year-old male who has history of trauma. Then in the emergency department, ED, you notice the patient has the blood pressure around 100/60 mm mercury, the pulse rate around 120 beats per minute. There is bruises in the abdomen with a seatbelt mark. So how would you approach this question? Okay, I would answer by saying, well, in hospital care, we will start with ATLS approach, Advanced Trauma Life Support approach. First, we will assess the airway and cervical spine, breathing and circulation as the primary survey for the initial assessment and management. ATLS aim is to treat the greatest threat of life with the immediate intervention as the threat of life is identified with the re-evaluation of initial management. Then later, we will proceed to secondary survey from head to toe evaluation. So what are the interventions during the primary survey? The interventions include 1. We must secure the airway while protecting the cervical spine. 2. We need to enhance oxygenation. Number 3. We need to provide ventilatory assistance or support. Number 4. We must stop or limit further hemorrhage. Number 5. We must gain a large intravenous IV access. Number 6. We must initiate volume replacement. And finally, number 7. We must obtain blood for laboratory and blood bank testing. So, ATLS, Advanced Trauma Life Support Management and Principle, involve in primary survey, whereby, again, we need to identify what is killing the patient, then involve in resuscitation to treat what is killing the patient. Then we proceed to secondary survey, whereby we proceed to identify other injuries that involve from head to toe evaluation, and finally the definitive care involve develop a definitive management plan. So I re-emphasize again what is ATLS is about. As was asked earlier, patient came to emergency department with BP of 100/60 mm mercury. The pulse rate is around 120 beats per minute. Patient is in type 3 hemorrhagic shock classification. Now, I am revisiting regarding the classes of hemorrhagic shock. The class will be divided into few parameters. A, the blood loss. B, the heart rate. C, the systolic blood pressure. D, the respiratory rate, RR. E, the hourly urine output measurement. F, the mental status. And G, finally, regarding the management of each classes. In class 1, there would be around 750 ml of blood loss. It's about 15% of total blood volume loss. The heart rate is less than 100 beats per minute. It should be normal. Patient has normal systolic blood pressure. The respiratory rate of around 14 to 20 per minute. The hourly urine output is more than 0.5 ml per kg or normal. patient would be slightly anxious. In this type 1 class of hemorrhagic shock, the management include fluid challenge. In class 2 of hemorrhagic shock, it involves patient loss around 750 to 1,500 ml of blood loss or 15 to 30% of blood volume loss. The heart rate will be more than 100 beats per minute, but the systolic blood pressure will be normal. The respiratory rate around 20 to 30 per minute, with hourly urine output is still more than 0.5 ml per kg, or around 20 to 30 ml per hour. Patient also would be slightly anxious. In this type 2 class of hemorrhagic shock, the management include fluid resuscitation. In class 3 of hemorrhagic shock, it involves the patient lost around 1,500 to 2,000 ml of blood or 30 to 40% of blood volume loss. The heart rate would be more than 120 beats per minute with a decrease in systolic blood pressure. The respiratory rate is about 30 to 40 beats, 30 to 40 per minute, with hourly urine output is less than 0.5 ml per kg or 5 to 15 ml per hour. The mental status of patient is, you will see him becoming more anxious. In this type 3 class of hemorrhagic shock, the management include fluid resuscitation and blood transfusion. And lastly, regarding the class 4 of hemorrhagic shock, it involves patient loss of more than 2,000 ml of blood loss or more than 40% of total blood volume loss. The heart rate is more than 140 beats per minute and there is markedly reduced in systolic blood pressure. The patient will be tachypneic with respiratory rate of more than 40 per minute. The hourly urine output will be minimal or nil. Patient will be confused. In this case, you need to aggressively fluid resuscitation the patient and with the blood and blood product transfusion. So how do you know whether patient is responsive to the initial fluid challenge or resuscitation? They will show signs of immediate and sustained return of vital signs. The BP will be normalized, the pulse rate will return to normal, the patient respiratory rate will be normalized, the ABG or B status shows no acidosis features with return of normal color and uric output more than 0.5 ml per kg per hour. We must be careful in patients who has transient response with later deterioration of vital signs or in patients with no improvement despite adequate resuscitation. I want to add additional notes regarding how do you decide whether patient is rapid responder or transient responder or non-responders and management for each of the responders. For the rapid responders, hemodynamically, patient will return to normal after resuscitation. The hemodynamics will remain stable even after reducing infusion to maintenance rate. Usually or probably, the causative factor, example bleeding, has stopped spontaneously. We can continue evaluation for source of bleeding. Patient might still need surgical intervention. For the transient responders, patient will decompensate once the fluid resuscitation is slowed down. The causative factor might be due to ongoing bleeding or inadequate resuscitation. The management involved is by increased fluid resuscitation and blood transfusion, either type specific or O negative. Patient might need surgical intervention to stop the bleeding. For the non-responders, patient is usually due to fail to respond to fluid and blood resuscitation. Usually, the patient involved are the one that has major blood loss, more than 40% of total blood volume, and still have an ongoing blood loss. In these non-responders, immediate surgical intervention is advocated or other cause of shock need to be ruled out. Example, the shock due to non-hemorrhagic shock. Example, cardiogenic shock. In this case, we need to request for echocardiography and look for his CVP, central venous pressure, and measure it. Again, as the first video, I will repeat that the DCO, Damage Control Orthopaedics, focus on 1. Control of hemorrhage. Number 2. Management of soft tissue. Number 3. Achievement of provisional fracture stability while avoiding another additional insults to the patient. I am quoting from Rotundo et al. 1993 from the damage control surgery. He said that his triad of death in severe trauma are 1. Hypothermia, 2. Metabolic acidosis, 3. Coagulation disorder. That means patient will succumb to death due to this causative factor. So how do you do a proper resuscitation in a patient? You must remember that shock is a state of generalized cellular hypoperfusion that lead to inadequate cellular oxygenation to meet body metabolic needs. Adequate resuscitation will help in treating shock. As soon as the first intravenous line is inserted, rapid crystalloid infusion should begin. In adult patient, he or she would be given 2 liters of ringer lactate or normal saline. For children, the initial administered crystalloid volume should be around 20 ml per kg. Patients who experience a transient response should receive an additional infusion of 2 liters of crystalloid. Patients in hemorrhagic shock for whom there is no improvement in blood pressure from initial crystalloid infusion or who transiently respond by the phase, a second bolus of crystalloid should be switched to the resuscitation with blood products. After transfusion of the first 2 units of packed cells, it is important to administer fresh plasma or thawed FFP, fresh frozen plasma, to avoid coagulopathy in a massively transfused patient. Remember the 3 triad of death? Usually, the target range of ratio between FFP to RBC around 2 to 3. We can give 1 unit of platelet for every 5 units of red blood cells. Finally, before we end the video, if you are asked in a viva question how much blood loss in A. Tibia fracture, B. Femur fracture, C. Pelvic fracture, D. Humerus fracture, and E. Radius or ulnar fracture, how would you answer? We will pause a bit. The answer is, drum roll please. For A. Tibia fracture, the estimated blood loss is around 500 to 1000 ml. For B. Femur fracture, the estimated blood loss is around 1000 to 2000 ml. For C. Pelvic fracture, estimated blood loss is massive. You need to aggressively resuscitate this patient. Usually, the blood loss is around 3 liters to 5 liters. For D. Humerus fracture, the estimated blood loss is around 750 ml. And E. For radius or ulnar fracture, the estimated blood loss is around 250 to 500 ml. Okay, that's all for today. I hope you have learned something from this video. See you next time. Bye.